want you to picture an engine, but not a car engine where you can just turn the key off, pop the hood, and, replace the spark plug while everything is cold and static.
Right.
This engine has to run 24 hours a day, 7 days a week for, 80 years. It cannot stop.
It can't.
If it stops for even 5 minutes, the machine it powers it's destroyed beyond repair. Now imagine the timing belt on this engine starts to slip, or the electrical firing order just goes haywire.
Mm-hmm.
You have to fix it, but you have to fix it while it is still running at full speed.
That is the terrifying reality of cardiac electrophysiology. We tend to think of the heart as a pump, plumbing, valves, pressure.
Yeah, the mechanical side.
Exactly.
Mm.
But before it can be a pump, it has to be an electrical generator. And when you look at the source material we have today on arrhythmias, you realize that the difference between a long, healthy life and sudden death is often just a fraction of a millisecond in electrical timing.
We are diving deep into that electrical system today. I was reading through this stack of research, the clinical guidelines, the pharmacology texts, and the terminology alone is intense.
That's a whole other language.
It really is. We aren't just talking about a skipped beat. We're talking about electrical anarchy. We're talking about twisting of the points. And we're talking about a class of drugs designed to save your life that, if you use them incorrectly, can kill you faster than the disease itself.
That paradox is really the core of what we need to unpack. The heart is this incredible intersection of, biology and physics. It's an electrical grid.
Right.
An arrhythmia is, simply put, a loss of that rhythm, an irregularity. But the scope is just massive. It ranges from, I drank too much coffee and felt a flutter to
the electrical grid has collapsed and there is zero output.
Precisely.
So let's establish the geography here, because the sources keep referring to upstairs and downstairs.
It's the most useful mental model, really. The heart is a two-story house. The upstairs rooms are the atria. Their job is to receive blood and prime the pump.
Okay.
The downstairs are the ventricles. That's the heavy machinery. The ventricles are the main pump that shoots blood to the lungs and the rest of the body.
And the rule of thumb seems to be, problems upstairs are messy, they're uncomfortable, but problems downstairs are lethal.
Broadly, yes. If the lights go out upstairs, gravity and passive flow still get some blood down to the pump, you can live with a chaotic upstairs.
But not downstairs.
But if the downstairs stops firing correctly, the lights go out everywhere.
Okay, so let's start with the mess upstairs. The sources describe supraventricular arrhythmias, or SVAs, and the big one, the one we all see in commercials and hear about constantly, is atrial fibrillation, AFib.
Mm-hmm.
The text uses a phrase that I just can't get out of my head, a bag of worms.
It's visceral, isn't it? But it's accurate. In a normal heart, the electrical signal starts at the top, the SA node, and it spreads out like a ripple in a calm pond, one smooth wave. The atria contract, squeezing blood down.
Yeah.
In atrial fibrillation, that pond is being pelted by a handful of gravel. You don't have one ripple. You have dozens of chaotic, competing electrical wavefronts just crashing into each other.
And the numbers here are just staggering. The text says in AFib that atria are firing at 400 to 600 beats per minute. That sounds physically impossible. How does the heart not just explode?
Well, the muscle itself isn't contracting 600 times. It can't. It's just quivering. It's vibrating. That's why we call it disorganized atrial activation.
So there's no real squeeze.
There is no squeeze. You lose the atrial pick, which is that final 20 to 30% of blood volume the atria push into the ventricles.
So the engine loses its turbocharger.
Essentially, yes. But to answer your question about why the heart doesn't explode, you have to thank the gatekeeper. The AV node.
Ah, the bridge.
This is the electrical bridge between the upstairs and downstairs, and it acts like a surge protector. The upstairs is screaming at 600 beats per minute, but the AV node says, whoa, hold on. It blocks most of those signals. It only lets some through.
But because the input is chaotic, the output must be chaotic too.
Precisely. The AV node is getting bombarded, so it lets signals through at random intervals. If you feel the pulse of someone with AFib, it's described clinically as irregularly irregular.
No pattern at all.
There is no pattern. It's just chaos. The rate might be 100, then 180, then back down to 120.
And how does that feel for the patient? What are they experiencing?
It feels like the heart is just flopping around in their chest. Palpitations, shortness of breath, fatigue. You lost that atrial kick, cardiac output drops, you just feel drained.
The list of causes is really interesting. It mentions organic heart disease, things like hypertension or valve issues that stretch the chambers, but then it lists high adrenergic tone.
That's doctor speak for high stress.
Yeah.
This is where lifestyle crashes right into biology.
Right.
Alcohol withdrawal is a classic trigger. We see this holiday heart syndrome after long weekends of binge drinking, sepsis, thyroid storms, or even just extreme physical exertion in someone who's untrained.
So anything that dumps a ton of adrenaline into the system.
Anything that dumps massive amounts of adrenaline into the system can trigger these chaotic loops.
Speaking of loops, let's talk about the orderly cousin of AFib, atrial flutter. This isn't a bag of worms. The source describes it as a sawtooth.
Right. If AFib is chaos, flutter is a short circuit. Imagine a dog chasing its tail around a coffee table.
Okay.
The electrical signal finds a specific pathway, usually around the tricuspid valve, and it just spins around and around and around.
And it's fast.
Extremely. The atrial rate is usually almost exactly 300 beats per minute. But unlike AFib, it's rhythmic. It's a machine gun.
Wow.
And again, the AV node saves you. It usually blocks every other beat. So if the top is going 300, the bottom goes 150. You feel a pulse of exactly 150, rock steady.
That brings us to PSVT, paroxysmal supraventricular tachycardia. The name alone sounds terrifying, but the mechanism it's fascinating. It's all about reentry. I want to stop here because this concept of reentry seems to underpin almost every single bad thing that can happen in the heart. How does it actually work?
Visualizing reentry it's critical. Imagine a racetrack that splits into two lanes, let's call them A and B, and then they merge back together at the end.
Oh, okay.
Lane A is the fast lane. Electricity just zips right through it. Lane B is the slow lane. It's like a muddy dirt road.
Okay, fast lane A and slow lane B. Got it.
Normally, the signal goes down both. It finishes lane A first, hits the merge point, and keeps going. The signal from lane B arrives late, hits the signal from A, and they just cancel each other out. End of story. One beat.
Simple enough.
But now, let's say you have a PVC, a premature beat. It arrives too early.
Okay.
Lane A, the fast lane, is tired. It hasn't recovered from the last beat yet, so it's closed for maintenance. But lane B, the slow lane, it recovers quickly. So the signal is blocked in lane A, but it travels down lane B.
So the signal is forced to take the dirt road?
It crawls down the dirt road.
Oh, me.
So by the time it gets to the bottom, something bad has happened. Lane A has had enough time to wake up. It's open again.
Right.
So the signal doesn't just go down to the ventricles. It makes a U-turn and shoots back up lane A in the wrong direction.
It goes backward up the highway.
Yes. And when it gets to the top, it turns around and goes back down lane B. And now you have a loop, a self-sustaining electrical tornado spinning around and around that circuit.
That's reentry.
That is reentry. And in PSVT, that loop is usually right inside the AV node itself.
So suddenly, out of nowhere, paroxysmal, your heart rate just jumps to 200.
Instantly. You're sitting on the couch and boom, the engine is redlining.
Wow.
And because it's going so fast, there's no time for the heart to fill with blood between beats. It's essentially pumping air. Blood pressure crashes. You feel a choking sensation, pressure in your neck, dizziness. You might faint, which we call syncope.
It's a mechanical failure caused by a software bug.
That's a great way to put it, yeah.
Okay, those are the upstairs issues. Scary, uncomfortable, but usually not immediately fatal because that AV node protects the basement.
Right, the gatekeeper.
Now we have to descend the stairs. We're entering the ventricles. And the tone of the research material, it just changes here. It gets much, much darker.
The stakes are infinitely higher. The ventricles are the power plant. If they misfire, you don't just get palpitations, you get collapse.
It starts with PVC's premature ventricular complexes. I feel like everyone I know has felt one of these, that weird thump in your chest when you're stressed or had too much espresso.
And in a structurally normal heart, they're almost always benign. It's just an irritable focus, a single cell in the ventricle that decides to fire off early.
Right.
The thump you actually feel isn't the PVC itself, it's the beat after the PVC. The heart pauses for a second to reset, it fills with extra blood, and then wham, a super strong contraction.
But the text warns that PVCs can be a harbinger, a warning sign.
Context is everything. If you're a healthy 25-year-old, a PVC is nothing. If you are a 65-year-old who just had a heart attack, a PVC is a red alert.
Why?
It suggests the electrical landscape of your ventricles is unstable. It suggests you are prone to ventricular tachycardia, or VT.
The danger zone. The definition here is 3 or more PVCs in a row at a rate faster than 100.
That's the clinical cutoff. If it lasts less than 30 seconds, we call it non-sustained VT. It's a warning shot across the bow. It says, hey, the conditions for a fatal loop are present.
And it lasts longer?
If it lasts longer than 30 seconds or if the patient collapses, it's sustained VT, and that is a full-blown emergency.
The text distinguishes between monomorphic and polymorphic VT. Why does the shape on the ECG matter to the person, holding the paddles?
It tells you the mechanism, which tells you the treatment. Monomorphic means one shape. Every spike on the ECG looks identical. That implies a fixed track, usually a scar from an old heart attack. The electricity is just spinning around a dead patch of tissue. It's a stable, albeit deadly, loop.
And polymorphic.
Many shapes. The spikes are changing height and width beat to beat. This implies the electrical environment itself is shifting. It's unstable, usually due to ischemia or like a blood flow orb. This is huge drug toxicity.
This leads us to the most visually described arrhythmia in the whole stack.
Torsade de pointe.
Twisting of the points.
It sounds like a ballet move.
It refers to the appearance on the ECG strip. It is hauntingly beautiful if you ignore what it means. The spikes get small, then they grow tall, then shrink again, as if the electrical axis of the heart is rotating around a central point. It looks like a twisted ribbon.
But what causes a ribbon? How does that happen?
This is where we have to talk about the QT interval. The QT interval is the time it takes for the heart to fire and then recharge, to reset the spring.
Okay.
If that recharge time takes too long, what we call long QT, the heart cells become vulnerable. They can fire again before they're fully reset. These are called early after depolarizations.
Sort of like sparks in a room filled with gas.
Exactly. A spark hits during that vulnerable window, and the rhythm just degenerates into torsade. And here is the dark irony we alluded to earlier. The most common cause of acquired torsade de pointe is the very medication we use to treat other heart problems. We are absolutely going to get to that paradox of treatment in a minute because it just blows my mind. But first, we have to finish this downward spiral. If VT or torsade isn't stopped, where does it end?
It ends in ventricular fibrillation, VF.
The source calls this electrical anarchy.
I don't think anarchy is strong enough. In VF, there is no coordination. Every single muscle fiber in the ventricle is contracting on its own, independent of its neighbor. The heart looks like a bag of worms, just like AFib, but this is the main pump.
So cardiac output is?
0. The patient is clinically dead within seconds. They collapse. There is no pulse. There's no blood pressure. The brain begins to die immediately.
So this is it. This is sudden cardiac arrest.
This is it. Unless you have a defibrillator right there to reset the entire grid, to shock every cell into silence so the natural pacemaker can take over again, survival is impossible.
That's the fast and chaotic side. But the outline also covers when the lights dim, the bradyarrhythmias, slow hearts.
Right, defined as less than 60 beats per minute. But again, context is everything. You're a runner. If your heart rate is 45 while you sleep, that's just high efficiency. That's high vagal tone. Your nervous system has a heavy foot on the brake pedal, which is healthy.
But for an 80-year-old, that's not good.
For an 80-year-old, it's likely sick sinus syndrome. The SA node, the natural pacemaker, is just wearing out. It's like an old spark plug that only fires every other time.
And what does that feel like?
The heart pauses. You feel dizzy, you pass out, because the pump just isn't cycling often enough to fight gravity and get blood to the brain.
And then there are the blocks, AV blocks.
Think of these as roadblocks on the highway between the atria and ventricles.
Okay.
First degree is just traffic congestion. The signal gets there, but it's late. We usually just watch this.
Second degree.
That's where some cars are getting turned around. You get a pattern. Beat, beat, drop. Beat, beat, drop.
And third degree is the worst, I assume.
Third degree is the bridge is out. Total dissociation.
But if the bridge is out, how is the person even alive?
The heart has a backup generator. The ventricles can pace themselves, but they are terrible at it. They fire at maybe 30 or 40 beats per minute. It's an escape rhythm.
Wow.
It's just enough to keep you from dying immediately, but you are in a very precarious state.
And the worst scenario listed here is Tachy-Brady syndrome, which that just sounds like a contradiction.
It's the binodal disease.
Yeah.
The patient has AFib, so their heart is racing at 160. Then suddenly the AFib stops, and the sinus node is so sick it doesn't wake up.
So the heart just stops?
A heart stops for 5-6 seconds, then it starts again, slowly. It is a nightmare to treat.
Why is it such a nightmare?
Because if you give a drug to slow down the racing part, you kill the slow part. If you give a drug to speed up the slow part, you trigger the racing part.
Which brings us to, I think, the most intellectually heavy part of this deep dive, the paradox of treatment. The source material has a section explicitly titled Pro-arrhythmia.
This concept changed everything in cardiology. For decades, the logic was simple. Arrhythmias are bad. Therefore, we should give drugs to suppress them. If we see a PVC, we should wipe it out.
Makes sense. Clean up the ECG. Make it look pretty.
Except it turns out that the drugs we use to clean up the ECG can kill the patient. Proarrhythmia means the drug causes a new, more dangerous arrhythmia.
We need to understand the weapons to understand the risk. The text lists the Vaughan Williams classification. It sounds like something out of a spy novel, but it's the periodic table of heart drugs.
That's a good way to put it. It classifies drugs based on which door or ion channel they block in the cell.
Okay.
Class I blocks sodium. Class 2 blocks beta receptors, so adrenaline. Class 3 blocks potassium. And Class 4 blocks calcium.
Let's look at Class 1 sodium channel blockers.
Think of sodium as the spark. Sodium rushing into the cell is what starts the heartbeat depolarization. Class I drugs like quinidine, lidocaine, flecainide, they physically sit in the sodium channel and block the door. They make the spark harder to ignite.
Which sounds good if the heart is too irritable.
In theory. But remember re-entry. That loop depends on slow conduction.
A dirt road.
Exactly. By blocking sodium, you slow the conduction speed even more. In a healthy heart, that might be fine. But in a damaged heart, say, after a heart attack, Class I, drugs like flecainide, which is a Class I, can slow the signal so much that it creates the perfect conditions for a lethal re-entrant loop.
Is this what happened in the CAST study? The outline mentions it specifically.
The Cardiac Arrhythmia Suppression Trial, CAST. This was the watershed moment. Doctors were giving flecainide to patients who had survived heart attacks to suppress those little PVCs. They thought they were saving lives.
Yeah, they weren't.
The study had to be stopped early because the patients taking the drug were dying at a significantly higher rate than the patients on the placebo.
They were dying of rhythm problems, the very thing the drug was supposed to stop.
Yes. The drug successfully suppressed the PVCs, but it made the heart susceptible to sustained ventricular tachycardia. We were treating the monitor, not the patient.
That is just chilling. Let's jump to Class 3, potassium channel blockers. This is where the drug amiodarone sits.
Right. Potassium is responsible for the reset, the repolarization. When potassium rushes out of the cell, the heart relaxes and recharges.
Okay.
Class 3 drugs block that exit. They hold the door shut. This extends the refractory period, the time when the heart cannot beat again.
So it forces the heart to take a breather.
Yes. It's very effective at stopping short circuits because the tissue just refuses to conduct the bad signal. Amiodarone is the king of this. It actually does a bit of everything. It blocks sodium, potassium, calcium, and beta receptors. It is a sledgehammer of cardiology.
But the side effects, I have a list here that reads like a horror movie.
It's a dirty drug. It goes everywhere. It can cause pulmonary fibrosis, literally turning your lungs into scar tissue. It can wreck your thyroid, making it hyper or hypoactive. It causes microdeposits in the corneas of your eyes.
And the skin thing, is that real?
Blue man syndrome, literally. Long-term use can turn sun-exposed skin a slate gray or blue color. It's permanent. But, and I cannot stress this enough, amiodarone saves lives. When a heart is in an electrical storm, amiodarone is often the only thing that will calm it down. It's a devil's bargain.
So we've got this arsenal of really dangerous drugs. How do doctors actually use them? Let's look at the strategy for atrial fibrillation. The text breaks it down into 3 goals: rate control, rhythm control, and stroke prevention.
This is the daily bread of cardiology. Goal 1, rate control. If the upstairs is going 600, we don't care about stopping the chaos immediately. We care about protecting the downstairs.
Okay, protect the ventricles first.
Exactly. We use beta blockers or calcium channel blockers, that's class 4V, to slow down the AV node. If the ventricles are beating at a nice calm 80 beats per minute, the patient feels fine, even if the atria is still fibrillating.
Goal 2, rhythm control. Trying to snap it back to normal.
We can use the heavy drugs like amiodarone, or we can use electricity, a cardio version. But we have to be really careful, which leads us to goal 3.
Stroke prevention. This connects the heart directly to the brain. Explain the mechanics here. Why does a fluttering heart cause a stroke?
Stasis. Blood pools in this little pocket called the left atrial appendage, and it forms a clot.
And if the heart suddenly goes back to a normal rhythm?
The atrium gives a big, strong squeeze, and it launches that clot like a missile. It goes straight up the carotid artery into the brain. Massive stroke.
So you can't just fix the rhythm whenever you want to.
Hence the 48-hour rule.
Yeah.
If a patient has been in AFib for more than 48 hours, you assume there is a clot in there. You cannot shock them.
What do you do?
You have to put them on blood thinners, warfarin, dabigatran for at least 3 weeks to dissolve or stabilize that clot. Only then is it safe to restart the engine.
This source mentions the CHEAT-2 score. Is this how you decide who gets the blood thinners?
Exactly. Not everyone with AFib needs heavy anticoagulation, which has its own bleeding risks, right? CHABS-2 is a risk calculator.
What's it stand for?
C for congestive heart failure, H for hypertension, A for age greater than 75, D for diabetes, and S for a history of stroke.
And the more points you have.
The more points you have, the higher the risk that your AFib will throw a clot. If the score is high, you get the blood thinners.
There's one strategy in here called pill in the pocket. It sounds a bit cowboy?
It's actually quite elegant, but it requires very strict selection. Imagine a young person. Their structural heart is perfect, no scarring. They get AFib maybe once a year.
Right.
Why put them on a toxic drug every single day? Instead, they carry a single large loading dose of flecainide or propafenone in their pocket.
And when they feel the palpitations start?
They pop the pill, it floods the system, blocks the sodium channels just enough to break the loop, and they convert back to normal sinus rhythm at home. But, and this is a massive but, you have to test them in the hospital first to make sure they don't have a proarrhythmic effect.
Right, because if they have hidden heart disease, that pill could trigger the Torsade or VT we talked about earlier. Speaking of Torsade, if a drug causes the twisting of the points, you surely can't give more antiarrhythmic drugs to fix it.
No, that just adds fuel to the fire. The antidote for Torsade is magnesium sulfate.
Just magnesium, like from a health food store.
IV magnesium. It stabilizes the membrane potential without slowing conduction further. It's almost magical to watch on a monitor. The twisting ribbon just flattens out into a normal rhythm.
We've talked a lot about this chemical warfare, but the outline suggests the whole field is moving away from drugs and toward hardware, non-drug interventions.
Because of the proarrhythmia problem, the fact that these drugs are double-edged swords, we now prefer mechanical solutions when we can.
Okay.
The most basic is DCC, direct current cardioversion.
The paddles. Clear.
We usually use adhesive patches now, but yes, that's the one. It's a hard reset. It depolarizes every single cell at once. It shuts everybody up so the SA node, the captain, can speak again. If a patient is unstable, low blood pressure, chest pain, we don't mess with pills. We shock them immediately.
But that doesn't cure the problem. It just resets it. What about a cure? The source talks about ablation.
Radiofrequency ablation. This is the engineering fix. Remember that reentry loop? The extra wire that causes PSVT or flutter.
The dirt road.
We thread a catheter up through the vein in the leg, right into the heart. We map the electricity point by point. We find that dirt road, and then we apply radiofrequency energy heat. We burn a tiny scar, just a few millimeters wide.
You intentionally scar the heart.
To break the circuit. Electricity cannot travel through a scar. We cut the wire. For PSVT and flutter, this is often curative. The patient walks out of the hospital cured. No drugs needed ever again.
And for the slow hearts, the sick sinus cases.
We install a new alternator, a pacemaker. It just watches the heart. If it sees a pause that's too long, it sends a tiny electrical impulse to force a beat.
And the big guns, the ICD.
The implantable cardioverter defibrillator. This is for the patient who has survived a cardiac arrest or is at very high risk for VT. It's basically a pacemaker with a shock function. It sits there, watching every single beat 24/7. If it sees the electrical anarchy of VF, it charges up and delivers a kick at defibrillation shock directly to the heart muscle.
It's a paramedic implanted in your chest.
It is. And unlike a drug like flecainide, which might prevent an arrhythmia or might cause one, the ICD is an insurance policy. It doesn't prevent the rhythm from starting, but it prevents you from dying from it.
So bringing this all together, we started by looking at the heart as this incredibly complex machine.
A machine that runs on a very, very strict schedule.
We've seen that the upstairs can tolerate a lot of chaos, AFib, flutter, but it comes at a cost to efficiency and, of course, stroke risk.
And we've seen that the downstairs tolerates no chaos. Chaos there is death.
The most profound takeaway for me is that shift in medical thinking. The move from suppress every skip with heavy drugs to manage the risk and use devices. The CAST study taught us that trying to force a perfect ECG on a damaged heart is a deadly vanity.
It taught us humility. The body's electrical system is resilient, but is also balanced on a knife edge of ion gradients. When we intervene with chemistry, we are reaching into a complex system we only partially understand. That's why we now prefer to burn the bad circuit or implant a safety net rather than flooding the whole system with sodium blockers that could backfire.
It really reinforces that image of the engine running at full speed. We're in there tinkering with the timing belt while doing 60 miles per hour.
And hoping we don't cause the piston to fire while the valve is open.
On that terrifying note, maybe take a moment to appreciate your pulse. It's doing a lot of math every single second to keep you upright. Thanks for listening to this deep dive into the electrical engineering of the human heart.
Stay curious.
We'll see you on the next one.